record, it's okay. Yeah, it's now
It's recording.
Great. Okay. Nice to see you all. Today I'm going to present more on our observation clinic uh, in Rotterdam in the Netherlands. I work for Slingerdaal. Slingerdaal is a long-term care facility for patients diagnosed with Wernicke-Korsakoff syndrome. And we have a long-term care facility for like around 150 patients and an observation clinic for around 30 patients. And usually people get admitted from the hospital with the first initial phase of Korsakoff syndrome called Wernicke's encephalopathy. I'm currently involved as a researcher for Slingerdaal. I've worked there since 2011. Initially, it was a much smaller center, but it's gradually becoming bigger, both regarding the number of patients, but also the number of projects we do. I collaborate a lot in the research team of Albert Posma. He's a full-time professor, and together we also give guidance to a couple of PhD projects. But today I will focus on Wernicke-Korsakoff syndrome. If you would like to read more on the acute phase of Korsakoff syndrome and the post-acute phase of Wernicke encephalopathy, I would like you to refer to this paper because we did write down what we actually do on our observation clinic in this paper. And it's more of a general idea, but what is required for patients in the initial phase diagnosed with Wernicke's encephalopathy. I will start off with a case study. Today's case study is a 38-year-old female, and it is an actual case from the clinic. She lives with her parents, and she has 10 days loss of visual sight. Not full loss, but there are some visual issues that she is complaining of. And also, she eats progressively worse in the last 3 months. And a detail which is quite relevant, she also drinks a liter of vodka every day. So she drinks quite a lot. And then she fell in the public transport, and she's moved to an emergency department of the hospital. In the emergency department, they see that she's disoriented in time and place. She also has some attentional difficulties. Her attention is of very short span, and she has ataxia of the legs, so a loss of power and coordination of the legs. On neurological examination, they see that her consciousness is not fully clear. There's the disorientation part. She doesn't know where she is. She doesn't know what time it is. There's also a bit of dysarthria. She's hard to understand. There are some motoric issues of the mouth. And if you ask her to repeat 3 words, she's not able to do so. And later on, she doesn't know she is asked these words. Her peripheral nerves are intact. And also she has horizontal nystagmus, which is actually a sign of Wernicke's encephalopathy. So the differential diagnosis in the hospital is Wernicke's encephalopathy. Also, alcohol withdrawal delirium could be differential. It might be that she has polyneuropathy following thiamine or other deficiencies. And it could be that she has longer existing cognitive deficits. Well, the case I presented has Wernicke's encephalopathy, and it's usually caused by thiamine deficiency, which is actually quite common in patients with alcoholic issues. And the issues start because if you consume a lot of alcohol, you do meet your glucose requirements, so you get a lot of sugar, but you do not get the vitamins, which are usually part of a regular diet. For example, vitamin B, you can get this from meat or bread, or also a lot of fruits and vegetables. And if you have a regular diet consisting of a variety of foods, then you can actually maintain a good vitamin B1 level. But in alcoholics, it's usually compromised. And Wernicke's encephalopathy is not on its own. There are a lot of other issues that can be seen in patients with alcoholic for example, they are often have a loss of reflexes. They are often very thin, or they lose weight. There's general weakness. And you can also get heart conditions if the thiamine deficiency is prolonged. And the early names for these were wet beriberi for the heart conditions and dry beriberi for the brain conditions. And it usually combines, so you can see a lot of heart issues also in patients with the acute phase of Wernicke's encephalopathy. Here I'm going to show you how nystagmus looks. So that's one of the three main issues in Wernicke. It's confusion, nystagmus, and ataxia. As you can see, the eyes are not fixed to one point, but they move a lot. And usually is horizontal, but it can also be upwards, like this or this. And if you, in the video, if you have the audio on, you can hear that the neurologist asked the patient to move her eyes from left to right. And actually then you can see it even more visible in the acute phase of Wernicke's encephalopathy. To diagnose Wernicke's encephalopathy, you can follow the Kane criteria, and they're represented here on the right. The essential thing is the dietary deficiency, so undernutrition, and you can see this in impaired dietary intake or an abnormal thiamine status if you look in the blood for thiamine, but also weight loss can be a sign of dietary deficiencies. And that's the essential part of the Kane criteria. And you need one additional criterion of Wernicke's encephalopathy to diagnose Wernicke encephalopathy. So the oculomotor abnormalities like the nystagmus you just saw could be one of them, but also cerebellar dysfunctions, unsteadiness, ataxia, issues with pointing, also heel shin testing, the knie-hakproef in Dutch. If you ask patients to move their legs, you can see cerebellar dysfunctions, or an altered mental status, such as confusion, disorientation. But also, if Wernicke progresses over time, it can develop into a comatose state or a loss of consciousness or memory impairments. But it's essential that you only need one additional symptom of Wernicke next to the dietary deficiency. It's not necessary to have all three the symptoms because that's usually a sign of late recognition. So if you're quick in diagnosing Wernicke and you treat it with thiamine injections, you usually see only one Wernicke symptom next to the dietary deficiency. To go back in time, Wernicke described his encephalopathy in 1881. He reported 3 patients, 2 alcoholic men, and also one patient and one woman who developed persistent vomiting due to pyloric stenosis after ingestion of sulfur acid. And it's important to know that Wernicke is not only visible in alcoholic patients, but also in non-alcoholic patients if they tend to show the undernutrition. In the case study, we did also see some signs of Wernicke in the MRI. Here we saw bilateral medial thalamus atrophy and in the periaqueductal gray matter. And if we look at a group of Wernicke patients, these are the common signs. So the periaqueductal gray matter, mammillary bodies, but also the medial thalamus or other parts of the thalamus. But it's important to know that it has a high specificity. So if you see this, it's likely to be a Wernicke case, but it has a low sensitivity. So almost half of the patients with Wernicke's encephalopathy doesn't have these signs on an MRI. And actually, if you see those signs, it's usually also related to worse outcome than if you do not see these signs. No. Sorry. The treatment of Wernicke's encephalopathy are vitamin injections, and the English guideline is the one which says you should continue for the longest, namely 3 times 500 milligrams per day until symptoms resolute. Some of the other European guidelines say for 3 to 5 days, or 6 days, or 4 days. But in the hospitals I saw the patients, I usually recommended longer treatments if patients were recognized later, because it sometimes results in improved cognition if you give it for a prolonged time. In this case study, she was moved to from the emergency department to the internal medicine department. Here I have a Dutch paper. I know some of you cannot read this, but many doctors in hospitals are not acquainted with Wernicke's encephalopathy. So 73% of the doctors which didn't have a specialty didn't recognize Wernicke in a non-alcoholic case. In an alcoholic case, almost 30% missed the case. So Wernicke is underdiagnosed based on presentation. So it's also relevant to be, to actually review patients that are at risk based on undernutrition. Regarding the case study, she had some recovery of her walking issues, but also some residual ataxia. Her cognitive status improved, but not fully. She was able to walk with a walker, so a chair. And she has additional urinary tract infections, and she's being treated with antibiotics on day 5. And she was registered for admission to the observation facility of Korsakoff Center Slingendahl. We retrospectively reviewed our cases on our observation ward, and infections were very common in Wernicke patients. More than half of our patients had forms of infections, for example, meningitis, pneumonia, urinary tract infections, abdominal infections, sepsis, epidema, also infections of unknown origin, seeing in the blood that infection markers are higher, but do not see the origin of the infection. And the infection markers were in fact related to cognitive outcome later on, specifically on executive functioning on the key search test. So it's relevant to also treat infections comorbidly to Wernicke encephalopathy. Also, the time in status at start is related to outcome. As you can see here in very interesting paper by Anneliese, looking at the timing levels and the memory performance, and there's actually a positive correlation between both. So if you have higher timing levels, the memory scores are usually better later on. So it could be a predictor. Now I'm going to tell more about the Korsakoff observation clinic network and also long-term care network, because I guess it's not so common in other countries in Europe or outside Europe. We have a number of specialized observation units, and the largest one is the Vincent van Gogh Institute in Venray, which is actually where some of our colleagues from EUREKA meeting also work. You also have the Winkler Clinic in Wolfhezen. There are also two other mental health care facilities having an observation clinic for Korsakoff syndrome. And in Slingendal is actually a nursing home, so it's a bit strange that we have an observation clinic. But in the Rotterdam area, the mental health care parties didn't want to have a Korsakoff clinic. So eventually the nursing home ended up with an observation clinic with specialized staff. Also, we have two target group expertise centra, Slingendal and Atlant Beekbergen. And we have 11 regional expertise centra also having long-term care facilities for Korsakoff syndrome. And if you look at the map of the Netherlands, you can see that there are throughout the entire Netherlands. So there's always a facility nearby. And we have a Dutch network called the Korsakoff Kenniscentrum. You can call them if you have a patient which has probable Korsakoff syndrome, and they will help you to get the patient registered at a facility in the Netherlands. And also we have a research infrastructure within the Netherlands with the aforementioned clinics doing research and participating in a multi-center research on Korsakoff syndrome. And here I'm going to tell more about a paper Roy Kessels and Yvonne Rensen also published recently. The specialized clinics have in common that they have multidisciplinary diagnostic workup with detoxification of alcohol. And in Slingendal, we usually do not do the detoxification, but the hospital already detoxified the patients before they go to the clinic. And all specialized Korsakoff clinics in the Netherlands realize prolonged alcohol abstinence before neuropsychological examination, at least 6 weeks of sobriety. So they are partially closed facilities to keep the patients abstinent from alcohol and neuropsychological assessment, but also neurological examination are part of the routine assessment in these clinics. And we all want to optimize somatic status, including medical history. And from our clinics, they go to sheltered living forms or specialized nursing homes or long-term care facilities. And the majority of patients live at home with Korsakoff syndrome with ambulatory care programs or supported living at home. And if patients do not develop neurocognitive issues, they go to regular addiction care facilities. Regarding the case study, she did go to Slingendal on day 10 of admission. She still had some dysarthria, so a speech therapist was involved. They did some assessment of the ataxia and walking issues, so a physical therapist was involved. There was an independence check, so the activities of daily living, or the EADL check by an occupational therapist. There was an initial assessment of cognitive functioning, a MOCA, and a talk with the psychologist and a specialist in geriatric medicine made the direction of the care plan, and also diagnosed unforeseen medical conditions. In this case, she also had signs of diabetes mellitus number 2. And there was a continuing treatment for Wernicke's encephalopathy. In this case, she got longer time in injections than the usual 5 days. She got it for like 10 days. And there was an intake with care staff and family of the patients. Regarding the prolonged time in injections, I would like to refer to a case series by Infante et al. In these case series, there were 2 patients involved receiving for time in injections for more than a year in both cases. And in both cases, the reason to give it for a prolonged time, so more than 5 days, was that the patients did develop additional neurological signs after time in was discontinued in a injection form. So if it was transferred to oral, so a pill, time in pill, the patients still developed additional signs of Wernicke's encephalopathy based on underlying conditions. And this case series points out that it could be relevant to give time in for a prolonged time, specifically in patients that have underlying conditions such as lymphoma, or in the case of the gastrectomy, so obesity surgery with additional infections. If there is not a stable somatic condition, it could be relevant to give it for a prolonged time. Now regarding our clinic, we have an observation clinic on the Groene Kruisweg. Around 30 patients are observed for at least 6, but usually 16 weeks. 90% of those patients are from hospitals, usually from the Rotterdam area in the Netherlands. And around 10% are from mental health care. Usually if they have issues already at home, they're detoxified at the mental health care facility for 1 or 2 weeks and then go to our observation clinic. And the criterion to admit our patients is based on the diagnosis of Wernicke encephalopathy or the possibility of Korsakoff syndrome, so the long phase, or the stable and chronic phase. Our observation is 16 weeks, assessment after 6 weeks, and the outcome is like 30% goes to long-term Korsakoff care, 30% to sheltered forms of living, 30% goes to home, and 10% has hybrid forms of care, for example, sheltered living, but still some Korsakoff care group involved. Our main goals of our facility is to detect undetected medical diagnosis, no consumption of alcohol, normalize weight, stabilize psychiatric issues, improve condition and fitness and cognition through structured days, and which is partially natural recovery. We do not actually have an intensive cognitive rehabilitation program. That is not part of our facility, but we tend to, for example, apply errorless learning to learn everyday activities, or use some devices to also give people additional structure. So our specialist gives the direction of the process, make the care plans, and also detects medical diagnosis. And a new study we're currently writing down is regarding timing or regarding vitamin D supplementation. Oh, sorry, I'm confused a bit. In this study, we looked into vitamin D and additional development of cancer, and we did find if we give vitamin D for prolonged times in high dosing, there was an additional effect leading to more diagnosis of cancer in our cohort. So we gave the advice to give vitamin D, but not in the highest concentrations, but a bit lower. And here's the effect, but then visible over time. The most important effect we did find was that many patients diagnosed with Korsakoff syndrome tend to develop forms of cancer within the following 5 years, with numbers which are like 10 to 12 times as high as in a general population. And also we looked into thiamine-related recovery, and we did find that patients that received higher doses of thiamine IV for prolonged times have higher cognitive outcomes, so better outcome. The issue is that we did this retrospectively, so we looked back into all our cases, and then we saw this effect. But it would be relevant to do this prospectively within time. And we're currently writing this up to get it published because there is the general assumption that it doesn't matter if you give high doses of thiamine, that you always have good outcome, but that's not true, specifically for the at-risk group for Korsakoff syndrome. Then regarding our team, the occupational therapist usually is involved to give wheelchairs and walkers, also do ADL observations, aiding specific complaints. And here's a study by Eline Beuner telling that ADL and cognitive impairment are related, and also staying at a nursing home for prolonged times and impaired awareness. We also have the physical therapists, and there are many practical ways to get patients active again by fitness. For example, using the silver fit, as you can see on the right, the upper part, on the upper picture, there's a guy riding a bicycle, and in the silver fit you can actually show, for example, everyday situations. So people can, for example, bicycle through Rotterdam to get to their original locations. And we also have balance training, and the physical therapy is quite intensive. We tend to apply this 5 times per week to get condition and physical fitness to a higher level. Regarding mobility in Wernicke-Korsakoff syndrome, usually patients are initially bedridden or need a wheelchair based on the motoric issues involved in Wernicke. But in a while they develop Korsakoff syndrome, and their motoric issues also tend to stabilize. And this was a hypothesis paper by Jan Winia regarding the course of outcome. And his idea was that based on the motoric recovery, you can also tell something about the cognitive recovery of the patients. And currently we're testing this hypothesis in a new population, and there are some effects which are actually comparable to the pictures I showed. So for example, in the first month or 2 months of admission, you can see stabilization of the motoric issues and also of cognition. We're now looking into if patients that do not require a walker or a wheelchair eventually will be more independent and have a better cognitive outcome. We also have a dietitian involved because patients are malnourished. They are often weakened by a lack of proteins, but also muscle loss. And there are a lot of ideas to increase body weight, but also get a good nutritional status based on food. So they usually give advice regarding salt restrictions, but also high protein and energy food, but also ideas how to give patients this food throughout the day. For example, they are involved in spreading meals throughout the day. So it can be that some patients need like 5 meals per day because they are very malnourished at the start. And it starts with a very early breakfast and giving additional foods throughout the process of recovery. They do bio measurements, and they also measure body mass index and fat-free mass index. Then the psychologists, usually they are involved in behavioral observations, so they try to observe the behavior of the patients based on, for example, the MPI-Q or meetings with the care staff. They're involved in making crisis signaling plans, for example, regarding aggressive patients. They make a signaling plan, what to do in certain phases of behavior. For example, if people are already a bit agitated, what should you do? And every patient on the observation clinic does have such a plan eventually to overcome, for example, aggression or other forms of repetitive behavior. And we also have a lot of structured day program. There's they do gardening next to the clinic. On the left, you can see a picture of the vegetables that are growing in the garden, and they have this throughout the day. There's also musical therapy on the observation clinic. They tend to do group therapy at least once or twice a week, but many patients also get individual musical therapy and creative therapy. And in the middle, you can see, well, it's actually a gift you can give to people. They make this in the center, the AMD, it's called. And you can buy gifts for people made by the clients. Also on the right, the train made in wood. So it's also part of the observation clinic is to give patients a scheduled day to improve their well-being. The total duration of our stay is 60 to 20 weeks. We have some phases within this observation, and we tend to discharge patients after 20 weeks, but there needs to be a follow-up clinic or follow-up situation. So it sometimes is longer if patients need to wait for next clinics to get them admitted, or if they go home to have the home care team available. All patients get a neuropsychological assessment with a general battery of neuropsychological tests. We always test memory, attention, praxis, executive functioning, perception, and social cognition. And it's also always part of a larger description of the patient, including talks with the patient, but also the families and the care staff, observations, questionnaires, and we always make a report on this. And I'm going to skip this. This is the key search task. You need to plan. So the right picture is a good planning, and the middle one not. You can see multiple planning issues in some patients, and there are also Korsakoff patients that actually are quite good on this task, but are less good on everyday planning in more unstructured situations. And regarding social cognition, I'm just gonna tell you a bit around, regarding this, because we did some research on this, and it's actually quite a hot topic now. As you all might know, it has different levels, social cognition. So initially there's emotion recognition and emotion perception, Level 2 is the processing of emotions, but also theory of mind, making ideas about other one's minds and your own mind. And in level 3, you're acting on social cognition, so it's moral decision making and reasoning. We did some studies on all aspects of social cognition in Korsakoff. Here, the first one actually done by Barbara Montagne, showing that patients with Korsakoff syndrome generally have more issues in recognizing emotions, specifically anger, disgust, fear, and also sadness to some extent. And we replicated this finding also on the Ekman phases of the face, so the more traditional emotion recognition task. And you can find it in many tasks that patients with Korsakoff syndrome do not score a maximum score on these tests. In one project, we also did the Salient test to test for theory of mind. Some of you might know this task, but it involves Sally and Anne, which are actually two puppets with a ball. Sally has a marble and she puts the marble into a basket. Then she goes out for a walk and takes the marble out of the basket and puts it into the box. And Sally comes back, but where will Sally look for a marble? Well, the good answer is the original answer, so the basket. But many patients with Korsakoff syndrome tend to say she will look in the box, but they can actually repeat the entire storyline. So it's not that they do not have the memory for it, but they actually have issues with the theory of mind, and they score on chance level. So about half of the patients are able to perform this correctly, and the other half not, which suggests that there are theory of mind issues. There are more elaborate ways to test this, but this is quite an easy example. And recently there was a publication on more complex tasks assessing theory of mind by the Pitel group, also showing deficits in theory of mind comparable to alcoholic patients. And we did studies on moral reasoning, and Nairobi Vlot did this project, and here we asked everyday and complex moral dilemmas. And the everyday dilemmas were, for example, can you cheat on a certain game? And first we asked patients, is it okay to do so? And then we asked why they performed like this. And a general tendency is that patients tend to say for themselves, I do not want to get caught. And they tend to say yes more. And in control participants, they tend to say, I need to follow the rules, which is actually a higher level of moral reasoning. But if you do a different perspective, for example, you ask, should your neighbor cheat, or is it okay if your neighbor cheats with a certain game? Then patients tend to say, well, my neighbor needs to follow the rules. But for the controls, they say, well, if they do not get caught. So there's an indirect effect there, showing that patients with Korsakoff syndrome have moral reasoning issues. And in this study, we related this to earlier delinquency. So if they actually stole things or got involved with the police, and there was a relationship between moral reasoning now and delinquent behavior before the diagnosis, suggesting some already compromised moral functioning. But there are also issues here. Then I go to the last part of my presentation. After the neuropsychological examination, there's always a care advice. Usually it's written down by the psychologist, but it's always within the team, also discussed within the team. As I already told, Some patients go to long-term care facilities, around 30%. 10% goes to dementia care because they actually have forms of dementia. And some go to sheltered forms of living. And as I see, the percentage are different from which I initially thought. I guess the percentages I show here are more representative of the actual situation, that about half of them go to Korsakoff Clinic and the other half go to other forms of care. The patients that go home, so the 10 to 20%, they usually get Korsakoff home support. In Dutch, it's called KBT. And it's visited by an ambulatory social worker or nurse once or twice per week. And there's usually also a case manager Korsakoff involved, which is actually different from the case manager dementia. And we're currently writing down what's make the difference between Korsakoff case management and dementia case management regarding specific roles. And Iris Gijsberts is doing a project on this. And on the right, you can see in Dutch, The Art of Case Management Korsakoff. We already published a role and competence document showing which type of roles are needed for Korsakoff at-home care. Our general results are quite okay, I guess. Usually is we're able to keep patients off alcohol, more than 90%. They all have care plans and follow-up. BMI usually increases, but also the MOCA and the condition and the POMA. But as you can see here, it's not that they reach the full scale. So usually patients at the end of the observation still have cognitive issues and still have conditional issues. But we see improvement throughout the observation and rehabilitation phase. Regarding our client, she made good recovery over time, and she walked without a walker after 6 weeks. Her weight increased 4 kilograms in 12 weeks. She still has mild neurocognitive deficits, specifically on the executive domain. Her POMA increased and also her condition. And regarding her, the advice was to go home with case management and at-home care team. And she is still living at home with such care now. So my conclusions are that time in injections are critical, and there seems to be a dose-response relationship with higher doses going for a better outcome. And the English guideline might be the better one, giving timing until symptoms resolute. Earlier recovery of Wernicke encephalopathy is very important regarding the follow-up, specifically attention for infections, but also time in status at forehand are needed. Treatment requires multiple disciplines working together, at least the physician, psychologist, physical therapist, occupational therapist. But as you can see, there are other disciplines also working together. Neuropsychological examination is critical after at least 6 weeks. And it's also necessary to give a care advice and follow-up, because usually if you do not do such a thing, patients get lost or are going home without a proper care or follow-up, and they tend to revisit the clinics after time. So I would like to thank the whole team working on the observation clinic. And do you have any questions?
Thanks a lot, Erik. I'm sure there are many questions. Who wants to start? I have questions, but I'm going to leave the... Feel free to just unmute and to ask your question.
I have a question, if I may. Thank you very much, Erik. I think your system in the Netherlands is quite unique and very, very great. I hope we could have something similar in Finland. My question actually is how do you diagnose Korsakoff syndrome in the post-acute phase? What criteria do you use? And
Yeah,
like I'm talking about persons who may not have a clear kind of like a diagnosed
yeah,
encephalopathy phase in the
yeah,
beginning, just
yeah,
like an amnesic memory issues. How do you diagnose them?
yeah, yeah. So I guess there are a couple of criteria here. So the neuropsychological assessment showing memory issues, that's critical. We always tend to make like a timeline of symptoms because it's not a gradual decline over time, but a acute decline over time. So we try to get as much information as possible on the background. Um, if it's unclear, we make an MRI of the brain to look for specific atrophy in the thalamus or mammillary bodies or the periaqueductal gray matter. And there's always the weight loss component, so the nutritional issues. There should be some signs of nutritional issues somewhere. So usually it's based on family stories on how the patient behaved before going to the clinic. And if there is a dip in functioning, we usually tend to think that this is the Wernicke's phase, but we're not sure because it's always post hoc. So these are the most common criteria we use. Are these familiar for you, Anina?
Yes, absolutely. They are. Since I'm a geriatrician, I often see patients in the post-acute phase, and it's quite common that they do not have a clear history of a diagnosed Wernicke encephalopathy, and it's often also common that they do not have a clear like a single like a drop in the kind of memory
Functioning.
symptoms, or more like a gradual
Yeah,
kind of decline or several drops, and it's a bit difficult to do the kind of differential diagnostics. Is this Korsakoff's or is this like does it have a multiple etiology or something? So yeah.
yeah, it's quite a heterogeneous group, of course. So we also see clients that have TBI combined with Korsakoff's or forms of dementia. Um, and we tend to follow these criteria I mentioned, but it's sometimes not clear. Sometimes you just have a mixed profile of memory decline, but we're not sure if it's a drop or a gradual decline. And then we tend to say we need to follow up these patients. So a couple of times per year we do this to be sure that it's a Korsakoff patient. Yeah.
Yeah. Thank you.
Other questions? So maybe I can ask mine, and there will be other questions after all. You spoke about dysarthria several
Yeah.
times, and I was wondering, I didn't know that was common. Is it common in your experience or not?
Yeah, in the very acute phase it is. So in the
Very acute.
Wernicke's phase you can see it quite often.
Okay.
Um, and well, it usually follows a certain pattern also. So I visited a lot of patients in the hospitals, and you usually see that there's a strength issue. So if I talk now with very much strength and pronunciation, but usually you see that patients tend to lower the volume over time.
Mhm.
Um,
But for
uh,
that for that patient that lasted, right?
yeah,
She still has dysarthria a few weeks later.
yeah, yeah. So it's not very common that it stays. Usually it goes away. But in the course of long-term care facility, we have some patients And sometimes it's based on cerebellar dysfunction, so it's more of a motoric
Thinking, yeah.
coordination issue. But it's also, I guess, it's also part of the Wernicke symptomatology, but not a common. Well, it's not a necessary criterion, but you can see it. Yeah.
And I had another question about the treatment you offer. You spoke about psychology, physical therapy, occupational therapy, and you did not speak about alcohol. And I was wondering whether that it is because it's not a problem anymore in the patients you have once they had this acute phase, even though this lady had she doesn't have a Korsakoff syndrome, right? She still has deficits, but she doesn't
Yeah.
have amnesia, right?
Yeah.
Okay.
Yes. Yes.
So do you offer like alcohol treatment or
No, not in the Slingendaal, for the Vincent van Gogh Institute, but also the other mental health care institutes. It's more common to give alcoholic treatment. If patients are, in fact, do not have Korsakoff syndrome but still have alcohol issues, we tend to admit them to alcoholic facilities in the region. So in the Rotterdam region, it's more strictly divided. And for many patients, it's not an issue because they're like motorically compromised, but also cognitive issues. But we still have like 10 to 20% of them do have active alcoholism requiring treatment. So we tend to follow this up after our observation. Yeah.
And I have a last question.
Yeah.
It's regarding your vitamin D results and
Yeah.
the fact that it seems, if I understood well, that a large dose of vitamin D is
Yeah.
associated with an increased risk of cancer, right?
Yeah. 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 This was also retrospective data. So we didn't do prospective data involving high doses and low doses of vitamin D, but we did find an effect of the highest dose leading to more forms of cancer.
So how do you explain that? What would
Yeah.
be the because I saw that when you have too much, I'm not a physician, so, but I saw that when you have too much vitamin, you're going to pee the vitamin. So it's not a big deal, but it seems that it can. Do you have any explanation of that?
Yeah. I guess it's Wernicke puts you in a bit of a frozen state or a less energy consuming state. But if you give vitamins, the body tends to go into a more active state, making new neurons, making new cells. But there is a risk of malignancy there because you boost it too much. But then again, you always should give vitamins, so it's a complex issue. We did actually start this research project based on the finding that we did have a lot of tumors in our long-term care patients. So almost all patients eventually developed cancer if they stayed long enough in our facility. And we do want to know why, because of course, it's based on also physical fitness and lifestyle, because they smoke a lot and drank a lot and didn't eat good. But it could be that vitamins play a role here. Yeah.
Okay.
May I add to that? I would be very cautious to draw conclusions on causality, of course, because it's an observational study, and it can easily be a confound of whatever severity of premorbid, comorbid diseases or whatever.
Yes, it's just that because we try to to make people think that it is important to give vitamins. So it's not the same kind of vitamins, but as you say, that's complicated to say that you must give as much thiamine, B1 vitamin as possible, but be careful to vitamin D because it can be, so that's well, yeah, that's not an easy.
No, it's a complicated advice. Yeah. Well, I would suggest. Well, it is. We did find some effects, but of course it's not causality because it's retrospective data, and it's also a very specific group, namely long-term care Korsakoff patients. But it might be that there is an effect of vitamin D in high doses or extremely high doses. So it could be that you should be at some that you should be a bit certain regarding the dose and not give vitamin D like it's candy. But I would suggest to read this paper because we cannot make a causal relationship. Of course, it's more like a cohort finding. Yeah.
Can I also ask something about this?
Yeah.
Isn't it also possible that those patients who use supplement vitamins more have like a worse starting point, right? Because if you need more supplementation of anything, that means that you have a bigger deficiency. So before you start supplementing these patients, couldn't it be that these patients already have a bigger risk, say for the patients that are staying in the facility as compared to the patients that are staying at home? Maybe
Yeah.
those that are staying at the facility before they came there, they drank more alcohol maybe than the patients that are able to stay at home and therefore have a higher risk.
That could also be a severity issue, of course. Yeah, that we only see the most severe patients having the most severe issues. Yeah, we know that patients tend to have vitamin D deficiencies also in the clinic. But also for this specific group of long-term care Korsakoff syndrome patients within nursing homes. But it could be a severity thing, yeah. Mm-hmm.
Other questions?
So, Erik,
Yeah.
it seems that about 50% of the patients that enter in the first phase, the intake unit,
Yeah.
they go to the long-term Korsakoff care.
Yeah.
It's about 50%. So the other 50% are lucky because they're treated properly or something like that. What would you advise to increase the numbers that are successfully treated in the initial stages? What could we do?
Well, we did see better percentages over time after visiting the hospitals regularly with vitamin B1 advices.
Yeah.
So we have expert meetings with specialists in the hospitals to give vitamin B1 immediately with at-risk individuals. So that's the most important part, I guess. Also because the medical physicians do not recognize Korsakoff syndrome or Wernicke. That's the most important thing, I guess.
So it's educating the medical staff. Are
Yeah.
there other things?
Well, it could be that the ambulatory alcohol care from the general physicians, but also from the nurses visiting patients at home, should be familiar with malnutrition and suggest patients to give vitamin. We did a study giving patients at home vitamins, resulting in better staying out of the clinic. And there is this, of course, this study from Australia where they added thiamine to flour, where it eventually ended up with less Korsakoff patients. So I guess in the preventive phase, you can do the most. And on the clinical part, it could be that more intensive cognitive rehabilitation is relevant, but I'm not sure. We still do not have this data. Yeah.
Other questions?
I had a small question, yes. Thank you for your presentation. It was very nice. My question is about the parallel that you drew between motor recovery and cognitive recovery. I think it's me that did not understood your point, but is it just to say that the timing is synced, or that one can predict the other? If you could come back to that, please.
Yeah. I guess it's synced in time. So the attentional difficulties are related to the motoric issues in the first 6 weeks of recovery. And if patients start to walk independently, they usually also have better attentional spans. So I guess it's just a general path of recovery from Wernicke's. Yeah.
Okay.
Yeah.
Thank you.
Maybe your last question? No, we're good. Everyone got a chance to ask a question to Erik? Yeah. Well, thanks a lot, Erik. I think next time we will have the pleasure to hear Albert, right? So we'll try to find the next best option for that. And thanks everyone for being present. And see you for the next one, the 5th one. Have a good day, everyone. Bye-bye.
Bye.
Bye.